Ladies and gentlemen, dear colleagues and friends, on behalf of INUS, the International Neurology Society, I welcome you all very much to this INUS educational video program entitled Neurology in Daily Practice. Maybe you had already the chance to see part 1 and part 2 dealing with history taking and clinical examination. Today we will present to you part 3 dealing with urodynamics. What are the aims of urodynamics? The aims are to reproduce symptoms under the condition of precise measurements in order to identify the underlying causes for the symptoms and findings. And urodynamics are indeed the key to understanding symptoms and blood dysfunction, and as well as understanding clinical relevance. Urodynamics are the only investigation which can record pressures within the bladder, and pressures are crucial for lower urinary tract function and morphology. The lower urinary tract and the upper urinary tract form one functional unit, and a high pressure situation in the lower urinary tract may also affect the upper urinary tract and may eventually kill kidneys. Together with Thomas Kessler and our Indian friend, Professor Pawan Vasudeva, head of the Department of Urology and Renal Transplant in the VM Medical College and Safdarjung Hospital in New Delhi, in this video we will present to you the following topics. Firstly, how to perform a valid video urodynamic investigation. Secondly, urodynamic patterns typically for cerebral, spinal suprasacral, spinal sacral, and subsacral lesions. And thirdly, video dynamics can detect risk factors in time before irreversible damage occurs.
I am Professor Pawan Vasudeva. We shall be doing urodynamic studies in patients with neurological diseases who have urological problems today. So this is our first patient, and Dr. Vijay, who's a resident, will assist me in this case. So here we have a 31-year-old gentleman who had a cerebrovascular accident 10 months back. Thereafter he developed urgency with urge urinary incontinence, the so-called non-invasive urodynamics. The bladder diary showed that he had a mean daytime frequency of 5, a functional bladder capacity of 350 cc, and mean number of incontinence episodes daily were 2. On the free flow, the maximum flow rate is 24 ml per second, and the post-void residual urine is 20 ml. Before we start, this is our urodynamic unit, this is our urodynamic machine, this is the urodynamic chair, and this is the C-arm. All procedures that are going to be demonstrated as per the ICS standard good urodynamic practices, we are going to be using fluid-filled catheters with external pressure transducers. Pressure transducers will be at the level of the upper edge of pubic symphysis, and zeroing will be done to the atmospheric pressure. We shall be using a 6 French double lumen catheter to measure intravesical pressure and a 10 French rectal catheter to measure the abdominal pressure. In patients in whom the rectum is not accessible due to congenital or surgical causes, the abdominal pressure may be measured by putting the rectal catheter into the intestinal stoma. So this line represents the vesical pressure, this line represents the abdominal pressure. Intravesical and abdominal pressures at the start of a urodynamic study are predominantly dependent on the position of the patient. Pressures of 5 to 20 centimeters of water are appropriate if the patient is in supine position. For sitting position, 15 to 40 centimeters of water, and for standing position, pressures between 30 to 60 centimeters of water are appropriate. Body weight may have an additional influence. At the start, detrusor pressure should be in the range of 0 to 6 centimeters of water. We can see that these pressures are fine because the patient is in semi-recumbent position. This line is representing the detrusor pressure, and then we have the flow line, and then this is the EMG. We will now fill the patient with 30 cc and then make him cough for quality control. Please cough. Vesical pressure and the abdominal pressure are rising synchronously and equally with negligible rise in the detrusor pressure, and the EMG has also shown a spike, so the quality signals are good. We would routinely ask the patient to cuff every 50 cc to check for quality signals. We see that the bladder is filling and is smooth walled and the bladder neck is closed. Are you feeling any sensation of fullness of the bladder? We can see that the bladder is filled to nearly 500 cc, but the patient does not report any sensation. Patient now reports urgency. We can see that the detrusor pressure is rising while the abdomen pressure is flat, which suggests that there is a neurogenic detrusor overactivity. The EMG at the same time has slightly increased. The detrusor overactivity has reached 36 centimeters of water. The patient has not leaked as yet, and there is rise in the EMG. We have stopped the filling pump, and the patient is reporting uncontrollable urge and wants to void. The patient is voiding, and we can see that the pressure has risen to about 50 centimeters of water. The abdomen is flat. The patient has a good flow, and the EMG is not totally relaxed. We can see that the patient has totally emptied his bladder. We will now ask the patient to cuff again to check for the quality signal. Please cuff.
So, in this 31-year-old man, 10 months after CVA, urgency and urge incontinence are due to cerebral terminal detrusor overactivity. However, bladder emptying itself is perfect, no post-void residual urine. Summarizing his urodynamics, you can say, voiding is right, but timing is wrong.
Our next patient is a 63-year-old gentleman with Parkinson's disease since 6 years. He has urinary symptoms in the form of urgency, urge urinary incontinence, increased daytime frequency, and nocturia since 1 year. Bladder diary shows that the patient has a daytime frequency of 6, nocturia 2 episodes, functional bladder capacity of 220 cc, and mean number of incontinence episodes being 2. Uroflowmetry shows a maximum flow rate of 5.6 ml per second and a post-void residual urine of 37 cc. The patient has a prostate size of 40 cc. The patient is in sitting position and we have started filling the bladder at the rate of 20 ml per minute. We have checked for quality signals. The patient is reporting the first sensation of filling at 149 cc. The patient reports urgency at 154 cc. We now see that there is a detrusor overactivity. We have asked the patient to try and control. He has not leaked as yet, and we'll stop the pump to see what happens. The pump has stopped, but the patient has not been able to control. The detrusor overactivity continues, and we now see that the patient is also leaking urine. On the video, we can see that the bladder outline is trabeculated, and this is the posterior urethra. The detrusor overactivity has resulted in the patient emptying to completion, albeit with a low flow.
In this 33-year-old patient with Parkinson's disease since 6 years, again, urgency and urge incontinence are due to cerebral detrusor overactivity. His poor flow, despite high detrusor pressure, is due to an infravesical obstruction, most probably to the enlarged prostate. The next patient also suffers from Parkinson's disease since 5 years and urinary tract symptoms since 1 year. However, his flow is perfect and there is no residual urine.
Now we can see a detrusor overactivity with simultaneous increase in the EMG activity. We have stopped the pump, but the patient continues to have urgency and says he will be unable to hold any longer. We have given him the permission to void. Patient is in the process of voiding and has generated a detrusor pressure of 26 centimeters of water. Patient has voided to near completion.
So the urodynamic diagnosis is cerebral detrusor overactivity with concomitant intermittent increased EMG activity caused by hold-on maneuvers when urgency comes up.
This is our next patient. He is a 29-year-old male with a traumatic C3 subluxation, incomplete lesion that he sustained in 2003. The patient has urgency, urge urinary incontinence, increased frequency, and unbalanced voiding. In the so-called non-invasive urodynamics, the bladder diary shows a mean CIC frequency of 4, mean CIC volume of 200 cc, and mean number of incontinence episodes being 2. As this is a lesion above T6, even though it is incomplete, we have to monitor the blood pressure for possible autonomic dysreflexia. The patient is in supine position. At a bladder volume of 75 cc, we see that the vesical pressure has increased, the abdominal pressure is flat, and the detrusor pressure has correspondingly increased. This is a detrusor overactivity, and we see that the EMG activity at the same time has increased. After stopping the pump, we still see that the detrusor overactivity continues unabated. The pressures have now increased to 125. The patient reports bladder urgency at this stage. Now we can see that the patient has leaked and is voiding, and the posterior urethra is dilated. We see reflux into the prostatic ducts and seminal vesicles.
In this high, incomplete tetraplegic man, we see spinal detrusor overactivity with pressures up to 100 centimeters of water combined with detrusor external sphincter dysynergia. The bladder is trabeculated, and we see reflux into the prostate and the seminal vesicles during voiding. This patient is in risk for upper urinary tract damage.
In patients with neurogenic lower urinary tract dysfunction, neurogenic bowel dysfunction is not uncommon. During urodynamic study, rectal overactivity may be present, causing phasic pressure rises. In this situation, the detrusor pressure is no more relevant, and the observation of intravesical pressure becomes important and can inform about the bladder pressure situation. Our next patient is a 35-year-old gentleman. He has paraparesis following a fracture of the T12 vertebrae in January 2019. He is unable to void since then and is on clean intermittent catheterization. The patient is in supine position, and we have started filling the bladder at the rate of 40 ml per minute. We have checked for quality control. We have filled the bladder to 400 cc, but he still has no sensation of bladder fullness. We are now asking him to try and see if he can void. The patient is applying abdominal pressure but has been unable to generate any detrusor pressure. He continues to try and void by Valsalva maneuver, but we see no contrast in the posterior urethra as yet. At this stage, maybe we should try to see if he can void without the catheter in the urethra. As you can see, we have removed the intravesical catheter to facilitate voiding by Valsalva. We can now see on the video that with straining, some contrast is seen to opacify the posterior urethra, though nothing seems to pass across the level of membranous urethra.
So this patient has a mixed spinal cord lesion after fracture of T12. He shows a flaccid paresis of the detrusor combined with a non-relaxing sphincter, clinically going along with a positive bulbocavernosus reflex. Bladder emptying by Valsalva or Credit maneuver is therefore impossible and IC is needed.
This is our next patient, who is a 45-year-old lady with history of diabetes mellitus since 5 years. She had a partial disc prolapse of the T12 vertebrae 2 years back. Thereafter, she developed frequency, urgency, and urge urinary incontinence. She presented 1 month back with vomiting, and her evaluation revealed bilateral hydroureteronephrosis with a serum creatinine of 2.3 mg per deciliter. She was referred to us and we put in an indwelling Foley catheter. Her serum creatinine has now decreased to 1.3 mg per deciliter. Quality control is good and the EMG is registering well. We can see that with hardly any filling, the detrusor pressure has started rising. The bladder outline looks irregular. The detrusor pressure is 30 centimeters of water with only 28 cc filling. Patient is now reporting urgency and pain. She says she will be unable to hold any longer. Filling is being terminated and she has been asked to void. She is trying to void with some abdominal effort. Minimum flow is visible but not recordable.
This lady has a painful, low compliance, low capacity bladder with severe bladder deformity, no detrusor contraction, minimal bladder emptying with abdominal straining.
In reflux cases, only video urodynamics can inform whether reflux is already present at a low bladder pressure, as in this case, or for example, only with voiding in a high pressure situation. This information may have clinical implications. As this patient is a walker, the video urodynamic study was done in a standing position.
Urodynamics is the gold standard for the evaluation of neurogenic lower urinary tract dysfunction. And this is the team of doctors which assisted us to perform this video. Many thanks for the excellent work they did. We hope you enjoyed this video and could benefit from it. At the end, I would like to thank Access to Healthcare Coloplast Partnership Program very much for supporting this ENUS educational video program.